Yeah.
But so everyone is unmuted. Welcome. Hi, everybody. It's Robin Shapiro. Nice to see you, Bruce Smith.
Hi there.
Hi. As people are signing on, I'm actually going to mute everybody. No, I'm not. Actually, I'm not going to mute everyone. We're expecting about 100 people to be signing on this morning to our community conversation. Good morning. It's June the 8th, and you're joining WASHA, the Washington State Health Advocacy Association, for our weekly community conversation. I'm delighted to welcome almost 60 people have signed on so far. We will be making this recording public. So if you do not want your video or your audio to be shared on this recording, please mute or turn off your video. We're having a few technical difficulties this morning. So thank you for your patience as we manage those. Today we're going to be talking about COVID-19 and navigating hospice. And I'm delighted to welcome, in addition to Dale Reisner, who hopefully we've troubleshot her technical difficulties getting on. We're also going to be joined by Stacey Jones, the director at Providence Hospice and Palliative Care, and Dr. Bruce Smith, who is the Hospice Medical Director at Providence Health Services. So I do see Dale has signed on. Dale, are you able to join us here?
Can you hear me?
Yes, I can hear you. Great.
Yeah, I do not know what's going on. My phone is the only thing that will access, and it's not wanting to connect the camera.
Okay.
Even though I'm clean and clothed.
Okay. All right. So as you all know, if you've attended a community conversation before, what we're going to do this morning is provide Dale Reisner, who is Medical Director, OBGYN Quality and Safety at Swedish Health Services, will give us an overview on COVID-19, what's happening in the health system, what's changed, and what to expect in the days and weeks ahead. We are very grateful for her to be able to do that weekly for us, and then we'll go ahead and launch into a conversation about navigating hospice amid COVID-19. So Dale, do you want to go ahead and take it away?
Yeah, so I wanted to give a little bit different view today. I looked at what's going on in the world, and one of the things that quite interesting is there are only 2 countries that are increasing right now. One is India, which has over 9,000 cases, new cases daily. And the biggest one is Brazil, which very disturbingly, as a small country, had 29,000 new cases. And compared to the United States, we're running 23,000 new cases. So you can see the different peaks of the different countries, and although new cases, it's lower than our peak in the country. And when you look at Washington State, as of Friday, we had, I don't know, somebody's got some music going there. We had 319 new cases, which is down considerably from what we've had in the past. So our overall statewide rates are better. We have now 7 counties, mostly eastern or rural. Spokane County is the biggest of the 7 that are now in phase 3. King County has gone into phase 1.5, whatever that exactly means. And then many of the states are in, or the counties are in phase 2 already. Phase 2 requires that we still keep physical distancing, that people should wear masks, and there's been some turmoil, not so much reported in Washington State, but around the US, with people refusing to use masks and violence associated with that. So I'm happy that we haven't seen any of those reports in our state. The other data it was going to give you for all of Washington State, we now have 23,442 confirmed cases with 3,600 hospitalizations, 1,153 deaths. So that's 4.9% of the confirmed cases are deaths. And if you look at our total testing, which has increased significantly, we're 400,500 total tests done, and of those tests, 5.9% are positive. So that speaks to about a 6% rate that's been pretty consistent the last few weeks of people who are positive, who may or may not have been symptomatic. Certainly, some of them are asymptomatic because some of that testing is pre-surgery or pre-delivery in various places around the state. I'm imagining the majority of this 400,000 are people that do have symptoms. However, not the biggest chunk are asymptomatic. King County, out of those deaths in the state, we're running about half. So we had 566 total deaths compared to the 1,153 in our state. So that just puts that into perspective. We had, as of Saturday, we had one day with 0 deaths. And so we're hoping that is amazing, and we're hoping that we stay with that. We are continuing to pick up new cases, but if we are able to minimize the deaths, obviously, that's a good sign. And the cases, of course, are wildly different in severity. So as we test more, we will see more people with mild symptoms who are going in for testing. And
so, I just want to pop in a question here, which is there is a question about any concerns in the medical community regarding the protests and projected spike in cases. Is that of concern?
Well, yes, as soon as large groups of people get together, of course, that's a concern. If you look at some of the recent marches, you will see pictures of a lot of people, the majority of people with masks on. Because obviously you cannot keep physical distancing when you're marching through streets with a large group of people. And there were some interesting sights, mostly from a big distance, from, I'm sure, drones or aerial, of major cities around the country with all the demonstrations that were going on and the protests that were going on this weekend. So yes, of course, if people are not careful, hand washing, hand sanitizer. I think in those situations, if you are in a place, if you're even in a store and somebody comes closer than 6 feet and you're not comfortable with it, pull out your hand sanitizer, keep your mask on, and try not to touch your face. So I think that we will see. We'll just have to see. It's probably a week before we would see a difference. Based on when symptoms emerge, anywhere from 3 days to 10 days probably before people get symptomatic. So I wanted to just mention that there is free testing in a lot of places if you are a member of a hospital organization. If you're a patient with any of the major hospital groups, you should be able to get testing if you have concerns. I would not go get a test if you're asymptomatic and you're in a high-risk group. Just stay at home. and be careful. But if you have mild symptoms and you're worried that you might be going to contaminate someone in the family or whatever, you should be able to get free testing. And there were sites that were opened in downtown Seattle for people in the area that the mayor announced over the weekend as well. Lots of hospitals are offering it for their patients. So there's that. And then any other questions, Robin, about just the testing and the general stuff? I wanted to mention the central nervous system things that we've seen.
Yeah, I think that would be good.
Sure. And I'm just going to quickly touch on this. It came out in the New York Times and also in some other areas. There is an article that is been published that has been approved for publication and has presented online. So I actually was able to get a copy of the whole article. Comes out of Spain. It speaks to all patients that were admitted to the hospital in March. In Spain, 841 patients who were hospitalized with COVID-19 with a mean age of 66. A little over half were male, and over half developed some sort of neurologic symptoms. And so I wanted to tell you what that means. It may be as nonspecific as headache or myalgias, body aches. We know that those come along with most viruses, and dizziness. So those are the milder set, and those are mostly in early stages of the disease. We've heard about this lack of smell and taste or taste alterations. That also tends to occur early. And in 60% of those people, they had those two symptoms as the first manifestation of COVID-19. They were also more frequent in these milder ones in the less severe cases.
Mm-hmm.
The more severe things are alterations of consciousness. So they might be something as simple as dizziness, and more complex as inability to walk properly, seizures, other types of balance issues, and then more severe things like stroke and inflammatory brain type of response to the virus.
So we're continuing to learn about
learning a
the
lot.
virus. Yeah.
Yeah. And there've been some mental things. So there was separate from this article, there was a young man whose mother passed away from COVID-19 at age 52 with no comorbidities, but she had, prior to her death, some psychotic type of symptoms. So it's been quite interesting to see the diversity of how this virus can express itself. So I'll just stop there.
So that's great. Thank you for that update. I just want to remind people that if you do have questions, please put them in the chat function, or you can raise your hand. We're going to move now to Stacey Jones and Dr. Bruce Smith, as they're going to be talking about the difference between hospice and palliative care, misconceptions of hospice pre-COVID-19, how hospice has changed with COVID-19, what's happening now, what will be the new normal with hospice moving forward, and some specific resources. And I just wanted to remind people that this call happened because you gave us feedback on the survey that you wanted to hear from experts in this area. So if you want to hear from other experts in other areas moving forward, just please fill out the survey that you receive after our call today. So with that, I'd like to hand it over to Stacey and Bruce.
Hi, this is Dr. Bruce Smith. I'm the Medical Director for Providence Hospice of Seattle, which is all of King County. I've been doing geriatrics and hospice and palliative care for 32 years. And just a quick introduction to what hospice is. Hospice is occasionally a place. A lot of people think hospice is a place where people go. And every now and then we do have patients in an inpatient setting like a hospital or a hospice care facility Mostly hospice is a plan of care that's delivered wherever the patient may be, in their own home most often, sometimes in an assisted living or adult family home or skilled nursing. It may be that they live on a boat and we go see them on their boat. They may live under the bridge, or they may live in a penthouse. And so we mostly do hospice wherever the patient wants it. So hospice is part of palliative care. Palliative care is the idea that we want to maximize control of patients' symptoms, even if we can't cure whatever the underlying disease process is. So all hospice is part of palliative care, but palliative care is a broader scope. It does not focus so much on patients who have a limited prognosis, which is where hospice really focuses. In the United States, we talk about hospice pretty much as defined by the Medicare hospice benefit, which came about in the early 80s. Medicare is its own separate health insurance program, of course, that insures all the seniors in the country and some disabled people too. Hospice under Medicare means that you have to be within 6 months of expected death as certified by 2 different physicians. So it's for folks with a limited prognosis. It does provide a 6-month window. That doesn't mean you can only be on hospice for 6 months. If you're still alive after 6 months but have life-limiting condition, we continue to do hospice care as approved by Medicare. We just had a patient on our service here in Seattle that was on hospice for 5 years. That's about the longest I've ever seen in my career. The average stay on hospice is about 2 weeks. So we like to help remind people that they're eligible for hospice long before they're actively dying. Hospice is an insurance benefit. So there's, in particularly with Medicare, but also most private insurance plans cover hospice too. It's an expanded benefit that includes holistic care. It includes social work and chaplaincy, counseling, nursing care, physician care, volunteers for ancillary for non-traditional care. It includes bereavement services after someone's died to help benefit family members or others. So it's an all-inclusive benefit. It includes the pharmacy costs. It includes all the durable medical equipment needs for a patient for a limited time span for folks who are near the end of life. When people enroll in hospice, they disenroll from their routine health plan. So whether that be Medicare or a Medicare Advantage plan or standard commercial insurance, United, Humana, Regents, whoever, they effectively disenroll from most of their routine insurance and enroll in hospice as a care provider. Most plans, including Medicare, still cover things outside of the life-limiting illness itself separately. So if you're on hospice for lung cancer and you happen to fall and break your hip, Medicare will still pay to get the hip fixed if that's appropriate, while hospice pays for everything related to the lung cancer.
And so then does Medicare pay for hospice?
Medicare does not, well, so Medicare administers the hospice benefit. The Medicare Trust Fund pays the hospice agency a flat daily rate. So it's a daily insurance plan.
Mm-hmm.
And patients continue to pay their usual Medicare premiums. They don't pay hospice anything. There's no deductibles or copays for hospice. Some private plans have some weird ideas about that, but mostly people follow the Medicare rules.
And can you clarify how much time hospice workers spend with the patient or family? So I think many people don't understand that.
Yeah, hospice, we don't come and move in with people, but we can be there a lot. So at a minimum, hospice teams visit patients at least every 2 weeks, and as much as 24 hours a day in some cases. So there is something called continuous home care, which euphemistically means it doesn't actually mean continuous. It means we have to be there at least 12 or 16 hours a day. I forget, Stacey can correct me. I think it's 12 hours a day minimum for continuous home care. So we do sometimes provide very heavy care in a patient's home or other setting. Hospice can cover care in a hospital. And if patients have high-level hospital care needs that we can't meet at home, the routine hospice care, routine home care usually means there's someone visiting at least once a week, at a minimum every 2 weeks, And usually that includes teams of a nurse, a social worker, a chaplain. If they're accepted, we don't mandate chaplains, but we offer them to everybody. And also home health aides that come in on behalf of hospice. So very often there's people there multiple days every week, and at a minimum every 2 weeks.
Great, thank you.
So I'll go ahead and share a little bit. So my name is Stacey Jones. I'm one of the directors of Hospice of Seattle, and I've been in hospice and palliative care since about 2001. And so I'll talk a little bit about the COVID pandemic and kind of how hospices have changed and adapted as the COVID pandemic has occurred. So just for everybody to be reassured, hospices across the nation have continued to care for patients during this pandemic. You know, I think most hospices in the country really feel like we are the experts in end-of-life care. So doesn't it make sense that we would continue to provide care, not only to any patient who is at the end of life, but also patients who are diagnosed with COVID illness and then who are dying. You know, the other thing that's really important about hospice to bring up is after a patient or after a loved one has died from hospice, hospice also provides grief support services. And so for a year or a little over a year, most hospices have grief support services counselors who often do in-person visits with family members, lead support groups, provide mailings of education, information about grief. And so the pandemic has added new layers to grief, right? That's already there during a time of sadness for their loved ones. So that's something that hospice also provides. I don't have national numbers, but I do have some numbers related to how many patients we have served on hospice since the pandemic has started. At one point, we had a little bit over 50 patients that we were serving that either had symptoms of COVID that weren't tested yet or who had a positive test for COVID.
And Stacey, how does that compare to your whole?
To our whole, yeah, we serve about 500 patients on a daily basis on average. Mm-hmm. And the good news is the numbers are going down for COVID positive patients. We still have maybe one or two coming on every day or every couple of days, but we're down into the low 30s. And we're going back and testing some of our patients who were tested early on to see whether they're negative now. And the good news is we've also had some patients who have done very well with their diagnosis of COVID and actually have graduated from hospice.
Which happens, right?
That's good news even in the elderly population that we've been serving.
We have a number of questions coming in.
Sure.
Hot topic. And could you clarify if the best way to enroll in hospice is through a physician or any other paths like that patients or advocates can take?
So there does need to be a doctor's order to enroll in hospice. Now, that being said, anyone can call a hospice and have conversation, have consultation at Hospice of Seattle. And most hospices will help you figure out how to get the order from the doctor or have the conversation with a physician if that's needed. But we do need an order from a doctor to start services. Most hospices have what's called an access or an intake group. So when you could call the hospice and just ask for somebody in intake to speak with, or work with the physician for the patient and have a conversation about their illness and if they meet that 6-month criteria.
So here's a question. Can a patient go into hospice if they decline COVID-19 treatments like ventilator intubation? And how does the 6-month terminal illness requirement play into that?
Yeah, so the 6-month requirement is, it's, you know, nobody has a crystal ball. Nobody knows exactly when somebody might die, but it's usually a physician's best estimate that the patient might die within the next 6 months. Similar to all of our patients, you know, if somebody declines treatment and no longer wants to be treated for their terminal illness, they can come on to hospice. So that would include patients who have COVID. You know, if they decide they don't want to continue treatment, or there's no hope that they're going to get better. I know there's not really any curative treatments out there. But, you know, if they decide they don't want to go to the hospital, prefer to stay at home, and the physician feels like they have a limited prognosis, then yes, they could come on to hospice. And we've actually worked with, you know, a lot of hospices are working with skilled nursing facilities, adult family homes, assisted livings, especially when patients would rather not go to the hospital and would rather stay in their place, you know, where they're living and have comfort care.
Yeah. So I have a question from Judy, who's a palliative care nurse at Seattle Cancer Care Alliance. And there are some questions from a family she's working with about whether or not they'll be able to have visitors from family or will be limited as in the hospital if you're on hospice. So can you speak to that, and if there are changes and now in the future previously?
Yeah, I mean, that's definitely been one of the challenges if you don't live, you know, if the person is not currently in their own home, right? And we've even had challenges as hospice care workers getting into a variety of settings. Some hospitals have stopped using what we call the GIP benefit, right? Where, like Dr. Smith was saying, if a patient's in hospital and they need comfort care and it really can't be managed at home, we have some good working relationships with these hospitals. And so we'll go in and help the hospital provide that comfort care, right? Because they see us as the experts and we give them guidance.
And this is Bruce. I'll just speak to the hospice and visitor issue too. There's nothing about being on hospice that would limit people's ability for families to come visit. And the good news is that lots of the skilled nursing and memory care units, et cetera, have had rules for a few months where no visitors are allowed. There's often a little caveat there, though, that no visitors allowed unless the patient's at end of life. So they often now are letting in more family members if a patient's on hospice. Some of those, particularly if they have COVID as well, the family members would have to wear personal protective equipment, PPE, which unfortunately the hospice, we don't have enough surplus to be able to provide those for family members. We're having a hard enough time getting supplies for our own staff. And most assisted livings or skilled nursing centers, they may not have adequate PPE for family members either, but some of them do. But the good news is that if someone's on hospice, sometimes it then gives you a pass that family members now are allowed to come in and visit because it's recognized that the patient's at end of life. We also have tried to facilitate video visits, Zoom visits, and Skype and FaceTime even sometimes with family members and their loved ones in facilities that are not allowing visitors. So we've even supplied some tablets to some facilities where they haven't been able to visit their family for months because of the COVID lockdown, separate from their family member's own illness. And now that they're nearing the end of life, it may be the only opportunity they've had to visit with their family members by a video link. So that's been kind of cool and kind of heartbreaking at the same time.
Yeah. We have a number of questions regarding racial disparities, and so I want to throw a couple of these specific questions out. Are you, Dr. Smith, aware of any racial disparities in the provision or acceptance of hospice care? That's one of the questions.
Not in the acceptance for hospice care. We see all comers and are happy to do so. We certainly know that the mortality rate is higher in some minority populations, from COVID in particular. But we see a full spectrum of ethnic groups and minorities. We have a translator service that provides translation to something like 32 different languages, because in King County there's a broad spectrum of immigrant populations. So there's no limitation as far as ethnic criteria getting into hospice.
Yeah, so and I think, and this comes from Judy Pickett, is there racial demographic data available, and maybe this is just even beyond our area, for hospice people and or providers? And I think maybe the question is, do people of color maybe have as equal access to different hospice services? Are you familiar with that? Is that like an area of study? And
there's a lot of data about it, and the challenge for all of us is that access in theory is equal. So people of all races and all minority groups have access to hospice. They tend to utilize it less than the majority population. So Blacks in particular have a lower utilization rate of hospice services for the same number of illnesses than the white population. And they spend more days in ICU, and they have more deaths in ICUs, which most people count as a bad quality measure. And so there's been a lot of work for 10 years at least in trying to work more with the minority community to help them understand that hospice is not about denying you appropriate care. It's not about doing less. It's not about pulling the plug or stopping things or pulling the curtain. It's about doing everything that's appropriate and helping avoid non-beneficial care. But many people don't have trust in the medical establishment, if you will, for good reason, because they have been denied appropriate care in the past, and they worry that hospice is just another way to ration care and to provide less care. And it couldn't be further from the truth. It's the opposite. But so we actively work to try to encourage better utilization of hospice, better agreement to hospice services when people are eligible for it.
So I have another follow-up. Oh, go ahead.
Oh, if I could say, yeah, and our National Hospice and Palliative Care Organization is a very active group, and they have lots of great statistics on different races utilizing hospice, and definitely, the African American population, other populations. It's been hard to, a lot of times they don't utilize hospice care at the same numbers that Caucasian people do.
So maybe that's an opportunity.
So that's always a challenge.
And they have less access to healthcare in general, and they more often are uninsured, and there's a whole myriad of reasons for why. But yes, it's frustrating that the numbers are not equal across the board.
So another few questions regarding how hospice is working in the home from people with some specificity. So, so when hospice workers are in the home with a patient, are there any restrictions as to how many people can be in the home? So if that's a family member or a visitor, does hospice have any policies about that now that we're in this?
Not specifically related to COVID or any, one of our biggest challenges, in fact, are people who don't have family members and live alone, but are becoming increasingly disabled and more dependent for assistance, but are relying on a neighbor who comes by once or twice. And so not having enough family members is a much bigger problem. Having too many family members, it's only a matter of who can fit in the room. We don't have a limit that you can, are limited to 2 visitors at a time or 2 family members or anything like that. We work actively with sometimes very large families and all the dynamics that go into that.
And those are the couple of the challenges too that we really had to think about as this COVID pandemic ramped up, was safety of our patients as well as safety of our employees when they're going into patient and family homes or wherever they live. So we do have very clear protocols on the type of personal protective equipment that our staff wear. So for all patients, our staff wear a face medical grade mask and a face shield. And then if they have any symptoms or they've tested positive for COVID, then they wear gloves and gowns, booties, things like that, right? So that's to protect the patients as well as to protect our staff.
And I
So,
see there's a question in the comments here wondering, do we require that there be a 24/7 caregiver at home? We do not. We encourage that if patients need that. But we accept lots of patients who live alone and prefer it that way and may need more help, but they don't want to get it. So we, try to work with them to figure out how to make that happen. But there's no mandate that people have to have 24/7 help at home. Some patients certainly could benefit from it.
And one of the great benefits to hospice care is each patient is assigned a social worker and their family. And so, as things begin to progress, if someone needs more care, maybe they're independent when they first come on hospice, but need more care as they decline, the social worker can help the family and the person who's on hospice really look at what are their financial means, what are their options if they don't have financial means for getting caregivers into the home, or what does the hospice need to do to train the family to provide more care.
So this is from Robert Free. He asks why there are no hospice care centers in the Seattle area or in probably many other areas. I don't know if you have an answer to that, but.
I keep asking that too. There's a wonderful hospice care center over in Kirkland. There's Evergreen Hospice has a beautiful place. There are hospice care centers in many communities, but the city of Seattle itself does not have a hospice care center. We primarily, we contract with 8 hospitals in the Seattle area to provide inpatient level care. Many of them have very home-like environment rooms, and it's not an ICU sterile kind of room. But I personally do feel it's a gap that there's no hospice care center, and have been lobbying for a long time that we ought to think about having one of those, whether it's Providence or somebody else or a consortium of hospices. I think it would be an asset for the community too.
Mm-hmm. I don't know, Dale, if you were trying to get in there or not.
Yeah, hey, I'm in.
Hey, you got a camera.
Yay! Okay, nice to see you. Did you want to jump in there, Dale?
Well, so I missed a little bit of it. One of the things I did want to talk about to add to the little bit earlier conversation about the racial disparities is I didn't report it, but I did get the numbers for Washington State on race, ethnicity for cases and deaths. And it might be helpful for folks on the phone to hear a little bit about this because it's interesting. There are, it's evident in the number of cases, but it's not evident in the percentage of deaths, which is good. And by far in our state, the Hispanic population, we have about 13% in our state, 41% positive rate in the cases for COVID-19.
Wow, so that's really different.
Really different. And their death rate is actually lower. And that may be because on the whole, it's not an old population. So the other is that we have a 4% Black population in Washington State, 6% case rate, but a 3% death rate compared to that 4% of the population. So
and do we know if that is also common for the rest of the country, or if that's just our area?
It's not the same in the rest of the country because, you know, the rest of the country has much higher rates of African-American population, much different living situations, so on. Not that ours are perfect, but We did see an increase in cases in the African American and other ethnicity populations in South King County and the SeaTac area I had mentioned before. And I think that's in part because of what they do for a living and where they live, and sometimes multi situations. But we don't have that really tight inner city living situation that many big cities do, where the outcomes are, the death rates are probably worse. So yeah.
Great, thanks for sharing that. I have another question here about many times patients have questions about whether hospice will interfere with other benefits, such as COPES or long-term care insurance benefits that pay for caregivers. So I think this person was just saying that hospice doesn't interfere with these things.
Correct. That's correct. Yes. Yep. Yes, you can still have a COPES caregiver if you have another benefit like a long-term care insurance that's providing in-home care, that the families can continue to have that, and the patient can continue to have that.
And Jennifer DeRosa mentions there are specific care acuity requirements people need to meet in order to receive hospice in a care center. So do you want to talk a little bit about that? Yeah,
so there's different levels of care within the hospice benefit, and one of them is called the general inpatient benefit, and basically that's for a patient that has acute symptoms that we're not able to treat in the home. So we've tried everything in the home and we just can't get their symptoms managed. So at that point, we would send them into a care center or one of our contracted hospitals to get the care that they need in a more setting and work with the staff there. Now, some hospice care centers do allow patients to stay in their care centers if they're not having active symptoms, but then the family has to pay their room and board for that. And sometimes it's hard to fill beds in a care center if that's what's needed, just because, you know, it's quite expensive to have to pay their room and board in a care center. So.
Sorry about that. I just muted myself. People were getting a little bit of feedback there. So thanks everybody. So can you talk a little bit about, I mean, it sounds like limiting access to people at end of life hasn't really been a big issue for hospice. We did have a question about, so thinking about the mix of things that hospice provides, which you listed, is the way that you're delivering some of that care in terms of the percentage of time that you're actually in the home versus maybe on the phone or telehealth, has that changed?
It definitely has changed. Our regulations prior to COVID really emphasized in-home visits, right? And that care that hospice provides is really seen as very intimate work, right? So it's sitting at the bedside of the patient, it's sitting on the couch with the daughter, providing education, providing training, providing support, sitting at the dining room table. But with COVID, and we've talked, and everybody knows about this from watching the news, the lack of PPE or the lack of equipment for care providers to provide care has been a challenge, even in home care and hospice care as well. And so the Centers for Medicare and Medicaid Services, who tells us what our regulations are, basically kind of pulled back on the regulations. So no longer did they say that almost, you know, most of the interaction that we do had to be in person, but we could now do it through telehealth, and we could now make phone calls and really have longer phone calls and telehealth visits as part of our care. So we have moved to doing quite a bit of telehealth visits. One of the things that our staff was really concerned about, were they still going to be able to have that intimate relationship that they do with that patient and family so that they know that we care, right? And they've been surprised that they've actually really been able to do that. And on some occasions, the families have been able to share more, and patients even over the phone, and maybe it's just because you're not face-to-face, have shared more about their concern, about kind of how they're coping. And it might be because we're in this pandemic as well, but just feeling like they have been able to make those connections. I can tell you a story. One of our social workers found out from a daughter of one of our patients in a skilled nursing facility that she, that she was very spiritual, that she was very religious. And so the social worker and the chaplain had one of the caregivers at the skilled nursing facility do a FaceTime visit, or a telehealth visit with our staff, and they did a virtual walking tour through the Sistine Chapel.
Wow.
And the woman who was on her service did have some dementia, but she seemed to really enjoy it. And so the daughter is from out of town, and initially the daughter was like, no, I don't need to be on a telehealth visit with my mom. I don't need to do that. But once she heard kind of what was happening in this visit, the daughter then wanted to be a part of future visits. So it was a way that we were really able to connect them and bring some meaning for this patient in a way that we might not have if they were just going to the nursing facility.
Mm-hmm.
It's just been a change, and it's been kind of a little scary for the staff, but they've been adapting, and I think a lot of the hospices in the country have moved to some of this type of work.
So do you think that will impact how hospice and the mix of services and the way that the services are done in the future will change?
We don't know yet.
We don't know, but our hope is.
We don't know what Medicare will allow us to keep doing. I think there's clearly a room for virtual visits. We can do a lot of good things. We can connect families across different states, in a family meeting kind of thing. I think there will always be a role for a bedside visit too. So a lot of our staff are really eager. They want to get back to the bedside as we allow, as the COVID restrictions loosen a little bit, we can do more in-person visits. And it's really hard to do a physical exam over Zoom. So getting back with the patients is something a lot of us are really looking forward to doing more of. But I think there will always be a role for telehealth, video visits, and even telephone visits. Medicare had not really allowed those at all previously, so hopefully they will not go all the way back to zero allowance. But there will be some allowance for when it's appropriate, how we can use those technologies.
And Beth Droppert also put in here that it's also easier to have long distance loved ones involved in visits and care, which I think in some ways this whole pandemic has really kind of leveled the playing field in terms of having more people involved who are spread out instead of having to get on an airplane and come and visit.
Robin, I can really speak to that as well. This is Sean D'Amelio. I have an aunt who is actively dying on hospice, and I have another aunt in Michigan, and she's heartbroken because she can't get to her fast enough to come see her. And so we've been coordinating a call and a Zoom call between the two of them, and it's really quite I think it's just, we're all thinking outside the box, and it's going to make a big difference across the board for people as a whole.
Yeah, thank you.
And definitely families have shared with us, I haven't been able to get there, but you helping me see my loved one and see that they're not suffering, that really brings me peace. So, yeah. And our hope is that the regulations won't go exactly back to the way they were, but there will be opportunities for that. And we will definitely advocate, hospices will advocate in with our National Hospice Organization for those.
So we had a question early on in terms of with so much loss that people are experiencing, not only end of life loss, how is hospice supporting kind of these multiple losses felt by not only the person who's dying, but loved ones and navigating that? And is that any different than how hospice supports families pre-COVID?
Mm-hmm, mm-hmm. Yeah, our grief support services here at Hospice of Seattle has really jumped in and both tried to help our employees with some of their own grief and loss, but looked at how has the pandemic affected what's going on. And I think some of the things you are talking about, right, that Sean was talking about, you can't just fly there and see your loved one now that's dying. So there's that loss and that guilt of not getting there, of not being able to be there for people who are out of town or who are not there. So that's really been some compounded grief there. So our grief support services staff doing virtual visits with people from out of town who in the past may not have wanted grief services, or we could connect to a local grief support services, we're actually providing that service for them now.
So just to clarify, you are providing virtual support groups. Are there actual grief group supports that are done virtually?
Right now we're really doing mostly one-on-one.
Mm-hmm.
They're looking at how to make support groups happen. Haven't quite gotten there yet, but we're looking at going that route.
And I believe that Bannister Advisors, they're here locally. Vanessa she's in our directory. I believe their organization is looking at offering or facilitating grief groups online. Yes. So just to think about that. And I see that Stephanie has her hand up. Stephanie, do you want to jump in here?
Yeah, just a quick plug for the telehealth to some extent in the appropriate situation. One, for me personally, I've been finding it incredibly useful and helpful, and very much less threatening for some families at home to get started initially. For instance, just this week I had a patient and family. I had a new puppy in the house, and the puppy sat with me on the screen, and they had their cockatoos on their shoulders. And it was an incredibly, just human experience versus more clinical and medical. It was super nice. So that's one piece I wanted to just throw out, that it can be a little bit less threatening. And two, for those that are in palliative care, but not necessarily hospice, I've been speaking to some palliative care docs, and the no-show rates now are like down to 0 for the clinical palliative care visits because they're doing telehealth. So, there's a place for this. That's my point.
Yeah, that's great. Thank you. And thanks for sharing that. I have another question here about, is there any data regarding infectivity rates among hospice staff? And is that something that staff are concerned about, or that patients and families should also be concerned about? Because I'm assuming that hospice workers go to a variety of different families' homes. So can you talk a little bit about that?
That is a big concern, and a lot of these senior living facilities early on in the outbreak were not letting anybody come visit, and even now there's plenty of them that only let our teams come in and see patients if we can attest that we haven't been to any other buildings where they have COVID. Of course, this being King County, pretty much every building has COVID, and the ones that don't just haven't done enough testing yet. We are being very careful, of course, with the safety of our own staff and that of our patients by making sure we're following the highest level of PPE guidelines. And everybody wears a mask and a face shield at every visit, and gloves and a gown when it's appropriate, and booty covers and all the rest. We practice hand hygiene religiously, no pun intended, for a Providence facility. And that's true whether it's in a patient's own home or in some congregate living setting or in a hospital setting. But there's a lot of anxiety about that. We have a lot of families who don't, who spend, usually not the patient, but their family members who don't want anybody from hospice coming into their home because they're worried we're going to bring something with us like COVID. So some of those folks, we are doing a lot of video visits with them. We have, as I say, there's some facilities who don't want to allow us in because we do go to other buildings. We've looked at having teams that only are the COVID positive teams and the COVID negative teams. But again, this being King County, that didn't work out too well because pretty much everybody sees somebody with COVID at some point. So we reassure people it's just like the ICU doc who takes care of COVID patients. They're going to go home. They're going to clean up and rest up and come back in the next day, and they may be seeing patients who do or don't have COVID. We practice all those same precautions. So we've done a really good job as best we can tell. There have been no cases of COVID as a consequence of hospice teams visiting. We test our own staff when they're taking part in facility care. We screen everybody at the start of every shift. We all get our little screening. I've got my screening badge on today from the front desk where they checked my temperature, and I had to answer now 9 questions about symptoms. So we're doing our best to control things. And so far, knock on wood, have done a really good job. We've had one employee who had COVID. She happily recovered and did well and got cleared and is back to work. But in spite of caring for lots and lots of COVID patients over lots and lots of visits, our staff have not been sick. And as best we can tell, we have not caused illness in anybody else. So yes, it's a concern just because of the nature of the work. But we're doing our best to keep it under control.
That sounds great. And as we're wrapping up, you might have seen that I just launched a poll. We do not have a topical speaker other than Dale Reisner, who's always providing us COVID-19 updates for next Monday. And so just launched a poll about whether or not attendees would like to participate in an open conversation with not a big focused agenda. This time today has gone by in just a blink, and it was a very, very hot topic. So if folks could fill out the survey, that would be great. As we're wrapping up here, we have just a couple more minutes, and I want to also let people know that if you are interested in getting a free CE for board certified patient advocate, that will be available for participating in this live call today, and will be instructions on that will come in an email follow-up. But in the meantime, I'm just wondering, Dr. Smith and Stacey Jones, if you have any kind of final thoughts as we're wrapping up the call here.
Not so much a summary thought, but as I'm looking at the chat, there's some questions about whether like room and board is covered in an inpatient setting or a hospital care or a hospice care center. And the answer is complicated because it's kind of like a hospital. If your room and board is covered when you're in a hospital as a routine hospital patient, if you meet the criteria to be in the hospital. If you just show up in the lobby with your overnight bag and you say, I'd like a room for the night, they're going to charge you for room and board. The same thing with inpatient hospice care, whether it's a hospice care center or in a hospital. If you qualify because you have high levels of care needs that cannot be met in an outpatient setting, then it's all covered, just like it would be in a hospital. If you're relatively well and you just prefer to stay there instead of going home, then you have to pay room and board. So that's kind of the balancing act. And then, of course, we all get to argue about how sick is sick. So that's a little bit more detail about whether room and board's covered in an inpatient setting or not. And just to thank you all for your interest in hospice and palliative care and anything to do with end-of-life care and how do we do a better job of caring for folks near the end of life, whether they have COVID or not. It's been one of my passions in life, and I'm happy to share that passion with all of you. If any of you have questions, I know Stacey and I are both open to getting emails or questions about hospice care in general, or Providence Hospice in Seattle in particular.
Yeah, I also want to thank everybody for being on the call and your willingness to learn more about hospice and the care that's provided at end of life. And I just really encourage you to advocate for those who are at end of life sooner than later about getting services, the hospice services.
Wonderful, thank you. And Dale, looks like you might want to jump in here.
I just want to thank both Bruce and Stacey for spending time with us today. Really, really important topic. And you're right, irrespective of COVID, it's super important. I guess I would throw out one thing for you guys. This is something we've been thinking about in the pregnancy arena, where doulas are advocates, and the discrepancy in outcomes between African American and particularly Native American for maternity. One of the things that we feel will help is having advocates, doulas of color, helping those folks navigate. And I'm wondering if you have looked at that within the hospice care in terms of bringing more African American families in and feeling comfortable. If
Dale, I think you cut out there.
Yeah.
So yes, we are actively working to increase diversity in our workforce. It's hard to go out and recruit people if they're not applying, but we do our best. We have a very broad ethnic swath of employees here in Providence and Seattle in particular, and in all of our other Providence hospice agencies around the state and elsewhere too. So yes, I think that's a big part of it, is how do we get more people who look like me to take care of me? And it's challenging.
And I think in light of everything that's going on, Providence as a health system, as well as Hospice of Seattle, is really looking at what are some of the disparities and what can we do. And that includes looking at our workforce and how can we increase diversity in our workforce.
And that is also a topic that WASH is very interested in bringing to these community conversations. So I would encourage folks that are on the line to suggest speakers that you want to hear from. And I just want to also say thank you so much for all the work that Stacey, Bruce, Dale, all of our healthcare workers are doing. Thank you so much. We're so appreciative of you, and really appreciative of your time. Today has been really wonderful and very direct. And I think that's so very helpful in these challenging times. So thank you so much. And we will make this available to folks and send you a survey. And I hope to see you again soon. Take care.
Thanks all.
thank you.